Hello and welcome to the Process and Documentation in the Internal Medicine module. The first section of Process and Documentation which you will need to learn is the admissions clerking. This will be one of the core tasks required from you. Having a good documentation skills and clerkship skills are going to be an advantage throughout your training. So how do admissions work? Patients in the medical department divisions are admitted either from the emergency department or outpatient medical clinic. Don't be surprised as you may also have to see patients that are referred from other departments, and this is called periphery referrals. Once the patient is seen in the emergency department or clinic and the decision to admit the patient to the ward has been made by the attending physician, the nurse in the emergency department or clinic will book a bed in the ward by liaising with the ward nurse. Once the bed in the ward is ready, the patient will be sent up to the ward. Admission docket will contain a patient's admission slip, payment receipt, and a clerical document in the clinic or emergency department done by the doctor attending. On arrival at the bed, the nurse in charge will ensure that the patient is safely transferred to the bed in the ward and will take the vital parameters to be recorded in the observation chart. The nurse will also inform you that the patient has arrived and ready to be clerked or attended to. What is the role of the house officer? As a house officer, you play quite an important role in clerking patients' history, performing physical examinations, ordering investigations including lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from senior colleagues or from your team members such as medical officers and or the physicians in charge. Admission clerking, as the name suggests, is carried out for the patients who are admitted to the medical wards. The house officer in charge of the new patient who is being admitted is expected to review the patient within 30 minutes from time of admission. Review the clerking which was done earlier in the clinic, emergency department or the periphery and have an idea of the case you might be dealing with to be able to revisit the history and fill up any more information left. Review the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, please alert your medical officer or physician immediately. From the emergency department, usually your medical officer would receive a referral call from the emergency department medical officer. Sometimes you may be in charge of the ED referrals for that day or may also be hand-chosen to go to see the patient first. Therefore, you will need to do a detailed clerking and perform necessary physical examinations prior to your MO's arrival. In cases where the medical officers are available, they would just go along with you to review the patient. Once x-rays and investigations are reviewed, patients will be admitted to the ward if necessary or else discharged with a to-come-again appointment or TCA. And when the patient is discharged from the ED, please do not forget to order the necessary medications such as analgesics or antibiotics if needed. How about patients from the periphery wards? The patients from the peripheries, also called ward referrals, may or may not be transferred to the medical wards, but a full clerking may be needed as soon as you review the patient. Any plans, investigations or orders to be carried out needs to be done by you and not the house officers from the respective departments. Discussion with the primary team on venipuncture schedules are also important to avoid bleeding the patient twice. When you are done with your clerking and physical examinations, you will need to present your case to the MO or physician who comes to review. Write or type out every point and plans given by your medical officers or physicians. Try to not take risk by just trying to remember verbal orders. That never works. Always make notes and whenever possible, get your MO to review what you have written or typed just to reconfirm. Once the patient is seen with your MO or specialist, always write their respective names on your clerkings, such as seen with Dr. A, discussed with Dr. B, or attended with Dr. C or Dr. E. Documentations are the utmost important factor, therefore pay attention to every single detail written or typed. Next, let's take a look at case presentation. So, a case presentation is a formal communication between healthcare professionals regarding a patient's clinical information. At its core, an oral case presentation functions as an argument. So, it is the job of the presenter to share the pertinent facts of a patient's case with the other members of the medical care team and establish a clear diagnosis and treatment plan. Thus, the presenter should strive to include details to support the proposed diagnosis and argue against alternative diagnosis as well as exclude extraneous information. While this task may seem daunting at first, with practice, it will become easier. While delivering an oral case presentation is a core skill for trainees, and there have been attempts to standardize the format, expectations still vary among attending physicians. This can be a frustrating experience for trainees, and I would recommend that you clarify your attendings' expectations at the beginning of each rotation. However, we have found that these differences are often stylistic and expectations for content are generally quite similar. Thus, developing a familiarity with the core elements of a strong oral case presentation is essential. So, how do you present a patient's case? Start with an opener. You should begin every oral presentation with a brief one liner that contains the patient's name, age, relevant past medical history, and chief complaint. Remember that the chief complaint is the reason that the patient sought medical care in his or her own words. An example of an effective opening is as follows. Mr. X is a 72-year-old male with a past medical history of hypertension and diabetes mellitus who presents to the hospital with complaints of left-sided chest pain which began this morning. Following the opener, elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. A useful mnemonic to use when deciding what to report is Socrates, which includes sight, where the patient is experiencing his or her symptoms, onset of the patient's symptom, C for characteristics of the symptoms, R for radiation to another location or is it well localized, A, any other associated symptoms experienced by the patient, time, cause of the symptoms, which stands for T, E, which is exacerbating and relieving factors, and S, severity of the symptoms. Next, let's look at past medical history. Here, you may want to dive into the past medical conditions that the patient has ever had or diagnosed and the medications that the patient is on. Sometimes past surgical histories may not be directly relevant to the issue. However, it is important to understand any past medical and surgical histories of the patient because this may be related or may contribute to the patient's current condition indirectly as well. When it comes to family history, you may want to then gather more relevant conditions that run in the patient's family with an emphasis on first degree relatives. After the family history comes social history. This section should include information about how the patient is coping with their symptoms and their support system, the patient's living situation, the patient's occupation, the patient's diet, any usage of alcohol, tobacco, and any other substances, or include any details regarding the patient's recent travel history. You may also include relevant details about the patient's education level, history of animal and occupational exposures, and religious beliefs. Review of symptoms. The review of symptoms is sometimes included in the history of presenting illness, but it may also be documented separately or presented separately. Review of symptoms include constitutional symptoms, central nervous system symptoms, respiratory system symptoms, cardiovascular, gastrointestinal, genitourinary, endocrine system, and also musculoskeletal system symptoms. Next, let's look at progress reviews. Daily reviews begin with morning reviews done as early as 7 a.m. You will be allotted a fixed number of beds in the ward, usually ranging 4 to 10 beds. Be familiar with the case that you'll be dealing with by looking through the current issues of the patient. There are some tips to speed up your understanding of the case before you begin your review. Ask yourself, why is the patient in the ward? How many days is the patient in so far? What have we done in terms of tests and treatment? What are the future plans or advanced plans? What are the impending test results for today? Make important notes on the side if there are any pending results so that you don't miss out to trace it again. Reviews are done usually 3 times a day by the house officer in charge unless an emergency sets in. AM review is done between 7 a.m. to 9 p.m. PM review is done between 2 p.m. to 4 p.m. On-call reviews are done between 8 p.m. to 12 a.m. Once you have done your reviews, present your review findings to your medical officer who will be doing his or her part of the review as well. There might be changes or additions to your review, so also remember to be at all times reachable. As you know, specialists have busy schedules, hence sometimes they would suddenly come in for sudden rounds, so you'd probably be wanting to be around for your patient. Document promptly so that the nurses will be able to carry out their part of the plan as well. Next, let's look at handovers. A handover occurs when a house officer hands over the responsibility of care to a patient to another house officer, for example, at the end of his or her shift. On average, handovers occur 3 times a day for each patient. Handovers occur at every level of care, from the consultants, specialists, and even amongst nurses once their shift ends. Handovers are very important to ensure a smooth transition, as you'll find much less disruption to team workflows and productivity rates. As a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient are not missed and to avoid wrong information passed over. So what entails a good handover? Patient's historical info, which comes under the past events. The patient's diagnosis, anything the team needs to know about them and their treatment plan. If they are newly admitted, and it's a good idea to cover the circumstances leading to their admissions. As for present events, importantly, present the current issues, how the patient has been this shift and any changes to their treatment plan. Keep in mind that significant changes might have occurred before your shift that the new team is not aware of, so check when they were last in and what they already know. Include physical observations and any results from assessments or investigations. As for future events, you have to investigate what is still to be done. For lots of reasons, there can be jobs that has to be handed over to the next shift. So tasks that needs to be completed at certain time or something that the team simply hasn't had time to do yet, and what to anticipate or watch out for during your shift to avoid unforeseen circumstances. Let's look at orders and requests. When a service from another department is required, a request is made. House officers are assigned to make requests following the plans in the daily reviews. How does a request work? First of all, identify the test that's going to be requested. Then identify which are the departments that are involved. Identify the officer in charge taking the request from the receiving department. Outline the indication for the request, urgency for the test to be done, how the test will be able to aid the diagnosis and management of the patient. Identify the criteria needed for the requested test. And finally, identify the documents that are required to be filled. Steps to place the request or orders begin with completing the request form for the test, which can be done either manually or using an electronic health information system. Next is to call or meet the officer in charge of receiving the request. Once granted, inform the ward nurse on the plan to transport the patient over to the location of the test or collect specimen for the test requested. Finally, document the trail, such as to who granted the test, when the test is planned for, preparation steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Now, these are characteristics of tests that require verbal communication and approval. Examples include radiographs reporting, urgent and early ultrasonography, urgent and early appointments for CT scans, urgent and early appointments for MRIs, group safe and hold and group cross-match codes, urgent full blood picture or peripheral blood film, and finally, echocardiogram. Remember not to request verbal orders for certain tests such as basic routine blood tests, radiographs, and non controlled medications. So these can be carried out without needing a verbal request. Next would be referrals. So, how do referrals work? Referrals are made to other departments for their management input, suggestions, or if their skill sets are required in the management of a patient. First of all, identify what is the indication of the referral. Understand how their input or intervention assists your team with the patient care plan. For instance, would their input be beneficial to establish a diagnosis, or assess the severity, or stage the disease, life-saving measures, and treatment plan? Identify which are the departments that are involved. Identify the medical officer in charge accepting referrals from the receiving department. Call the medical officer in charge for the interdepartmental referrals which require verbal communication, and then finally document the trail, which is the time of referral being made, the indication, and the medical officer who had accepted the referral. If your referral is not accepted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Next would be an example of a phone referral. So remember to communicate clearly and confidently when introducing yourself. You can start off by saying, "Good morning, Dr. Alex. I'm Dr. Betty, house officer from the General Medical Department." Next, state the patient's details followed by reason for admission to your ward and finally the reason for referral. I would like to refer to the case of a patient named Mr. Sim, a 56-year-old man who has existing diabetes on oral medications. He is currently admitted to the general medical ward for acute coronary syndrome and has been on double antiplatelet as well as anticoagulant for the past 3 days. Today, he had complained of passing black tarry foul-smelling stools which we suspect to be melena. His vital signs include the follows. When you're presenting a case, always remember you need to have updates of all relevant investigations prior to calling the medical officer or specialist in charge so that you'd be ready to answer their questions regarding the patient. So remember, in this situation, you might want to have a full blood count of the patient to depict the drop in HB levels from 10 to 8, for example, and over the duration of period. Finally, thank the medical officer or specialist for receiving the referral and attending to the patient. Lastly, discharges. A discharge summary plays a crucial role in keeping patients safe after leaving a hospital. So, hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. There are 6 main components in a discharge summary. It begins with reason for hospitalization, significant findings, procedures and treatment provided, the patient's discharge condition, the patient and family instructions as appropriate, and finally, the attending physician's signature. And now, what do you need to do prior to allowing patients back home? You'll finally need to make sure that patient's general condition is well and all plans given by the specialist are carried out. Remember to order discharge medications early so patients will receive them on time. This ensures a smoother process flow. Should there be a need for a medical certificate to be issued, inform your medical officer or physician to fill the certificate before the patient leaves, as this will be included in their discharge docket. If the patient has to be co-managed with other specialties, communicate the discharge plan to them will be necessary to ensure that there's no clashing plans or appointments. We have finally come to the end of this session. Thank you for your time.